Hello, Robert Bastian here of Laryngopedia and Bastian Voice Institute. This is a second video about the concept of vocal rapport, self-rapport. In a previous video, I introduced the concept, and before we get to the idea of an inventory, which is what I'm mainly interested in here, let me first briefly revisit the core idea. I define vocal rapport as a person's ability to connect with and manipulate their own voice. It involves both auditory and kinesthetic awareness, how the voice feels and sounds, and how you use the sound in your ear to redirect your voice to do different things. You also might think of it as the individual's relationship with their voice. Is it close and mutual, like a long and trusted friend? Or is it a distant and superficial relationship, like a vague acquaintance? Well, pitch alignment, pitch matching is, of course, a key part of vocal rapport. There are a lot of other things. There's respiratory control, there's loudness, there's voice quality, there's awareness of the larynx's position in the neck. If we imagine a continuum of vocal rapport, from weak to strong, a world-class opera singer, a ventriloquist, or a skilled mimic would fall far on the strong side, and a non-singer or tone-deaf person might be on the weak end. And of course, most people would lie somewhere in between. Well, why does vocal rapport matter, especially in the clinic? Years ago, I began teaching a three-part integrative diagnostic model, and vocal rapport is critical for part 2. So the model, just to summarize briefly, part one is what the patient tells you about their voice. That's the history. Part 2 is what the voice tells you, and the voice can be considered as a source of independent information. Put a person behind a screen and you don't know who they are, and just interact through that screen, and you can learn a huge amount about what's going on with that voice. It's assessment of what I call vocal phenomenology, and it is elicited through a vocal capability battery. And the clinician has to administer that vocal capability battery, and a lot of it is by using their own voice to say, can you do this? And then part 3, so it's what the patient tells you, what the voice tells you, the vocal capability battery, that's part 2. That's where vocal rapport is necessary, and then what the larynx tells you through a very high quality examination of the larynx. Well, each part requires distinct expertise, but repeating, it's that part 2, interpreting what the voice tells us, that is often overlooked, and where vocal rapport on the part of the clinician becomes critical. So to make that even clearer, let's consider an analogy. Suppose you want to improve your singing and you go to a teacher but discover she's tone deaf. How can she accurately assess or guide your voice? Of course, she's not even going to be a singing teacher. It would be impossible. And now flip the scenario. Suppose the clinician, the laryngologist or speech pathologist, has poor vocal self-rapport. How can they effectively elicit or evaluate a patient's vocal capabilities, limitations, or aberrations? Let's imagine that the clinician has very good vocal rapport, but the patient doesn't. So what does that introduce to the scenario? Well, let's return to the singing studio analogy. A teacher with tremendous vocal rapport, say a famous opera singer who's now teaching, she would still struggle to teach a tone-deaf student. That student would just fail to kind of perceive or comprehend or respond to the things that she asked them to do, not because their vocal cords couldn't do the things she wanted them to do, but because that ear-brain-larynx connection isn't there. It's deficient in some people, and they'll just never be opera singers. Well, it's the same in the clinic. If I ask a patient to do "ee," and instead they go "ee," I don't know anything about their vocal capability to go up there. I only know about their rapport with that task. So I've learned something powerful. This person has very poor vocal rapport. And of course, I can work in other ways to figure out whether the upper voice has limitations or not, but it's going to be a struggle because of the patient's difficulty in responding to what I'm asking them to do. In my patient notes, I've described poor vocal rapport with a brief clinical note like could not assess upper voice adequately because of the patient's lack of vocal rapport. And by that I just mean they couldn't kind of do what I asked them to do. I couldn't learn what I wanted to learn because I couldn't get them to do what I wanted them to do. And I would say they are unable to match pitch, poor vocal rapport. But I started wondering, could we go further? Could we semi-objectify the idea of vocal rapport? And what if we just took a minute to evaluate rapport itself? Now, in evaluating rapport, you might learn things about capabilities. There might be aberrations that crop up, but your focus for 1 minute is, does this person have good rapport or not? So I thought I would just spill out an inventory of things you could ask people to do to evaluate their rapport, not their capability. Well, a little self-disclosure, as some of you who've looked at other videos may have guessed, my natural leaning is toward thought experiments and conceptual frameworks and sort of creative thinking. I'm not as much into formal publications and footnoting, and I've certainly done my share of that, but it's not my leaning. So take what follows as exploratory, and I'll perhaps be able to codify better later, or somebody listening to this will do a better job of it. We're talking about a scale of vocal rapport, and we're going to look at the patient's awareness and control of respiration, glottal closure, pitch, register, stability, and finesse. So this could eventually allow a person to say, well, the patient scored 5 out of 10 on a vocal rapport inventory or something of that sort. Well, what would be included? One would be respiration, inspiration, expiration, that ability to control and go between them very quickly. And I would do that with panting and say, could you pant like this? Go. And believe it or not, there are people who can't do that. It's very foreign to them to figure out how to pant like a dog. They'll go, ha, 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 ha. So it's all out. They don't know the, ha, ha, ha. Or you can ask them to do inspiratory and expiratory phonation, and they can't do that. That tests their rapport with a combination of phonation and respiration. You could ask them for that siren up and down, the E and the E, and that assesses their awareness of pitch direction. And you could do a glottal stop. You could say, can you do a ha, 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 ha? And that assesses their ability to mimic and to address closure of the larynx without phonation. Vocal fry, that's in chest register, and it tests the idea that their ability to figure out how to compress, use very low airflow, and mimic what I've done. And you can also do creaky voice, so it's the same kind of compression and low airflow, but it's in falsetto register. Creaky voice. You could ask them to do chest versus falsetto, long ago people found versus long ago people found, and a little asterisk here because the vocal registers are set up differently in different voices. So there are actually people who have perfectly normal larynx and very good vocal rapport, but they can't figure out, yodeling is just not an option for them because of the way their registers are set up. Pitch matching, and that could be not just accuracy, but also rapidity of pitch matching. So, some people can get the pitch, but they kind of wander around. It takes them a moment to find the pitch, and that evaluates the ear-larynx connection. You could do low larynx phonation, like ask them if they know how to talk like Yogi Bear. Low larynx phonation, that checks their rapport with the visceral compartment of their neck, the laryngeal position in the neck up and down. You could do breathy phonation. Long ago people found, and there are people who can't do that. They can't figure out how to make the voice but in a breathy way. You could do inspiratory speech. You could do luffing. That's where you allow the vocal cords to go limp. Long ago people found that it was easier. So it's a very high airflow with fluttery vocal cords. You could do reading to children. That measures inflection, pitch, agility, and expressive range. And interestingly, there are people who can find high pitches, but they can't integrate that into ongoing reading. They're unable to do, long ago, people found that it was easier to travel on water than on land. They can't figure out how to do that. They can do a sort of an emphasis reading to children. Long ago, people found that it was easier to travel, but they can't figure out how to kind of vary their pitch. Well, that's a lot of different ideas. So maybe a quick test or a shorter version would be just the panting, the inspiratory, expiratory phonation, siren up and down, falsetto versus chest, low larynx phonation, and pitch matching. That could be a brief inventory of vocal rapport. Closing thought, there's a difference between, again, vocal capability, that's what the larynx can do, and vocal rapport, how well a person can engage with what their larynx can do. So understanding both is essential, especially in a voice clinic where sometimes we have to make very nuanced diagnoses. So this video is a first step, and I will try to refine this a little bit in future work. And maybe if you are so inclined, send me a little comment about what you think of the individual little tasks, the overall concept, and any other comments you might have. I'd appreciate. Thanks very much for listening.